closing the gaps, and I think the advances in TB that are coming out is tremendous. HIV was the epidemic, say 20 years back. Then we had COVID, which turned out to be a pandemic. And TB has always remained the epidemic for the last 10 years, especially drug-resistant TB. So the government has got very actively involved due to the involvement of our Prime Minister. And WHO had set a goal of elimination of TB by the year 2030. Government of India has actually set a goal of elimination by 2025. And what do you mean by elimination is that you don't have more than 44 new TB cases or 65 total cases per lakh population by the year 2025. We are nowhere near that target. But we are working hard, and I must appreciate that the government is doing a lot of efforts to get this gap closing for elimination. The amount of incentives that are given to the patients, the way that these patients are tracked, it's phenomenal. It's like how COVID used to be tracked, these patients are being tracked. There's a Nishchay ID that is formed. Every patient is tracked right from the laboratory to the clinician till the treatment completion. And there's incentive to the patient. They get nutritional allowance, they get treatment completion allowance. So there's a lot of incentives which go straight into their bank accounts, straight from the government. So lots of incentives that are offered. As Rajendra said, that we have a problem of guidelines between IIP and government, and now these guidelines are almost similar. The thing is, TB advances in the world is occurring to such an extent that you have new guidelines coming every 6 months. So you need to actually keep yourself updated with the guidelines. So I'm not going to jump onto the guidelines. What I'm going to say is, what are these updates which are helping to close the gap? One is we have updates in diagnostics. Second, the places from we take samples. We usually used to take gastric aspirate, BAL, but there are other places now which you can take samples from. Treatment, the guidelines keep on changing, a lot of new research, lots of new trials keep on happening, and so you get a lot of new regimens that come into place. And obviously, if you're talking about elimination, you need to remove the pool of latent TB. So latent TB guidelines also have got changed recently. Now, diagnostics, we all are aware about Xpert. In areas which don't have Xpert, they have a local PCR machine, a CB-NAT machine, which is known as TrueNAT. This is made in India product. The only problem is it's not fully automated like Xpert. So you need to do a little bit of processing outside before you can put it into the machine. So TrueNAT is not really done in the city of Mumbai. City of Mumbai, we stick to Xpert. And then you have these line probe assays where you look at PCRs for your second line drugs. You look for PCRs for your isoniazide. So these are already in place with the government. Xpert is done free of cost through the government program. So every patient will undergo a Xpert free of cost. Line probe assay is also done free of cost. The problem with line probe assay, it's supposed to give you a result in 72 hours, but we have such a long waiting list that by the time the report comes, it's 3 months. So a lot of times we have to look at other alternatives where we want to look, okay, Xpert showed rifampicin resistance. I want to know whether other second line drugs will work or not. So I need something that gives me a report much faster. Now, Xpert, the problem was it was very good for pulmonary samples, but it was not very good for extrapulmonary samples. The yield was only 50% because it picks up around 130 colony forming units per ml. So the makers have come out with the Xpert Ultra, which is more sensitive. It picks up 16 colony forming units per ml. So you will pick up more chances of your negative samples being caught as positive. So that's the advantage of an Ultra. The thing is, the Ultra is still not in the program, so it's not free of cost for the patients. We do Ultra in patients who can afford. So especially I would ask a CSF sample to try and do an Ultra. The cost of an Ultra is around 1800 rupees, but the yield is much better. So in your patients who can afford, you can try to do an Ultra. As I told you, line probe assay, the waiting time is too long. So we have now Xpert XDR panel. So in this XDR panel, it also checks for resistance to INH, fluoroquinolones, your second line injectables, that is your amikacin, kanamycin, capreomycin, and ethionamide. So if I have a drug sensitive, so if I have rifampicin sensitive, and I want to know whether INH monoresistance is not there, I can do this Xpert Ultra, XDR panel. If I have a rifampicin resistance, and I want to know whether I should add quinolone into that protocol or I should not add, I immediately get an answer. This test takes 4 hours to do with a waiting time that you have, collection of sample. The machine will take only 90 minutes, but by the time you get a report, it's 4 hours. It really changes your management because you start an NDR regimen right from the beginning which suits the patient. Most of the times we have to wait for an LPA report, or we have to wait for a culture with a DST and then see the report. So it takes, by the time it's 3 months, you actually end up changing the regimen. So here you can change the regimen immediately, or you can formulate a regimen immediately. Cost, it's around 4,000 rupees to do this test, but it's excellent. So we've been using this test quite a lot of times in Vadia, and we've had excellent results. Just to highlight, we had a 2.5-year-old boy. He had fever, vomiting and convulsion. MRI showed hydrocephalus with leptomeningeal enhancement with tuberculosis. Gene Xpert Ultra was rifampicin resistance, CSF. Now his XDR panel. If I have a CNS TB, I always look at ethionamide, whether I can give ethionamide or not, because ethionamide has got an excellent drug penetration into the CNS. So my XDR panel showed that CAG mutation is present, so I cannot use INH high dose, but I could use ethionamide. If I go as per the epidemiological pattern in Mumbai, ethionamide doesn't work for more than 50% of our patients. So I would have actually, when I would have devised the regimen in this trial, I would have not started ethionamide. But because I had a report which says I could use ethionamide, the regimen changed. And fluoroquinolone resistance is the tune of 60 to 70% in Mumbai. So you're always very scared to add fluoroquinolones into your DRTB regimen. So here we started this regimen with bedaquiline, linezolid, high-dose moxiflox, clofazimine, cycloserine, along with ethionamide the same day. So he was on the optimum DRTB regimen right from day one. So this is the advantage that we had by doing an XDR panel. You don't need to send an extra sample also. The same sample that is being sent for Gene Xpert, you just ask the lab to process that sample for the XDR panel. Now, other things that have occurred in diagnostics is genetic sequencing. We have already started doing whole genome, whole exome sequencing, clinical exome for genetic disorders. Similarly, the mycobacterium, you could do pyrosequencing. You could do next generation sequencing. These are all still on trial basis. Some labs have started doing it commercially. But I'll tell you the problems we face with pyrosequencing. Sometimes we do get patients who have undergone pyrosequencing and come with the reports. And then when you do the DST, it doesn't match at all. So then you don't know whether to treat as per the pyrosequencing report or you treat as per the DST reports. So they are still not standardized. JJ Hospital trial is going on with the pyrosequencing. They've approached us also for pyrosequencing. So once these are in place and we get proper information for this, I would not recommend you doing genetic sequencing. This will be definitely the test of the future. Nobody is going to look at PCRs then. Everybody will be looking at pyrosequencing or genetic sequencing. We used to do for diagnosing latent TB, we used to use Mantoux test. Now the problems with Mantoux was your BCG would give a false positive report. Your environmental mycobacteria, the non-tuberculous mycobacteria, the NTNs, would give a false positive report. So you would get a lot of reports, children who would be Mantoux positive, and you don't know whether there's TB, is it BCG, is it NTN. So you had these interferon gamma release assays. The mechanism is the same. It's a hypersensitivity reaction, just like Mantoux, except that the hypersensitivity reaction is done in vitro. So you collect the blood. The antigen is different. In your in your Mantoux test, it's usually PPD, purified protein derivative. So the antigen was very broad spectrum for a lot of kind of microbacteria. Here you have these antigens which are very specific. So you have your ESAT6 and CFP10. So it's very specific for Mycobacterium tuberculosis. 1 or 2 NTMs it can cross-react. And they give you release of interferon, which you measure quantitatively. So the test currently WHO which has recommended is Quantiferon TB Gold and TB Spot. In Mumbai we are doing TB Gold. So most of your labs will do TB Gold. Now the government of India has actually put Quantiferon TB Gold into the program. So everybody who's now being checked for latent TB undergoes Quantiferon TB Gold. So it doesn't say now that you do MANTU, it says that you do this. The thing is, the patient doesn't have to come back after 48 hours to do a reading. The patient just gets a report from the lab. The only problem is it's expensive, it's around 2,200 rupees. Through the program, it's done free of cost, but it's done only in the BMC centers. So wherever there are centers that have takes, so the patient has to go to that center to get the test done. So that's the problem with Quantiferon TB Gold. But it's available in most of the labs. So if you do it, this will be the amount. Now, the other test that is available and trials have been conducted in India with ICMR, and I think there were 10 centers in India who participated in this trial. So you have another skin test which is known as CTB, and CTB was developed in Denmark. Instead of PPDS, it uses the same antigens that are there in Quantiferon TB Gold. The same way you do a MANTU test, you inject intradermally and read the report after 24 to 48 hours. Anything more than 5 millimeters is positive. So it's a skin test. So very soon this will be rolled out as replacement towards MANTU. Now this was about the diagnostics, and we will go into what is happening in the updates regarding sampling. As I said, we used to do gastric lavage or aspirate BAL, or we used to do tissue samples. So if it's ascitic fluid or lymph node tissue, or you do a CSF or a bone tissue, depending on which part of the body has been involved. So these are the samples that we used to take. The problem in children, getting a BAL, if you have Parmath in your center, you can do a BAL. But otherwise, you can't do a BAL at every center. Gastric aspirate and lavage. Have you all ever tried to put a pipe through your nose? So it's not easy to do that in a child, even though you may say just come in the morning, empty stomach, and you'll put a pipe and remove the aspirate. The yield is only 50% with gastric aspirate. So it's not that great a yield, and it's a very uncomfortable test to do. So they looked at data. One was stool, whether we can do a stool gene expert and see whether we can pick up the mycobacteria. Because it's acid fast, so even if the child has swallowed the stool, the sputum, it should still come positive in the stool. So there is a Bangladesh study which looked at ultra on stool, and they found a sensitivity and specificity of 58.6 and 88.1. We have been doing stool gene expert, we have not been doing ultra, and we've got good results. When we are comparing it with the gastric lavage, we find that the stool, in fact in 2 patients, actually picked it up where the lavage was negative. So stool is one sample that we can look for. Government of India has still not implemented stool into its program because they want to do some research, operational research, before they implement that. So this was a case that we had. This was in the surgical ward. This child came with abdominal pain and distension for 2 days, vomiting, fever. He was diagnosed to have intestinal perforation with sealed off peritonitis with a omental caking and necrotic mesenteric nodes, suspected to have disseminated TB. The GL gene expert was negative, so obviously we needed something from the abdomen. So surgeons were planning to do a omental biopsy. We said, let's wait, let's try stool. So the stool gene expert ultra came positive. So we avoided a surgery in the patient. So this is what helps. But stool will be only useful if it's intestinal TB or it's pulmonary TB, not for other samples. There was another WHO paper which says nasopharyngeal aspirate for TB, but I don't think we can use nasopharyngeal aspirate for the time being because the way we collect nasopharyngeal aspirate is quite erroneous. And the yield is the least among all the samples. Then people have tried a mask. So the child or the adult will breathe into a mask which contains gelatin. And then that gelatin is checked on the PCR to see whether there is... so that study is also going on. So probably in the future we may just have a mass sample So they just have to breathe into the mask and we will get the results. Now if we look at what are the updates into the treatment. So we have new drugs and we have new treatment regimen. Say for example, DSTB, we usually treat with 2 months of intensive phase consisting of HRZE, and then we have 4 months of HRE. Earlier we used to have category 1 and category 3 and severe TB non-severe. Now it's standard, everybody goes on this regimen. Except in cases of spinal and neuro TB, the duration would be of the consolidation phase would be around 10 months, so total 1 year of therapy. So this is the standard treatment that we have. What is the update? The dosings are changing. We used to give INH earlier at 5 mg per kg, now we are giving 10 mg per kg. Rifampicin we used to give at 10 mg, now we are giving at 15. Why are we getting that dosing which is changing? Because based on the PK/PD data. Still we don't know the optimum dosing for CNS TB. So there are a lot of studies going on in CNS TB, what should be the optimum dosing that is going to be recommended. But you had this new regimen that came out with WHO, which the government has still not implemented. One, they said for non-severe TB, you could use 4 months therapy. So you use 4 months of 2 HRZE and 2 months of HR. So in India, we'll be using 2 HRE. So this was the regimen that WHO has recommended, of which one of the center was actually the SHINE trial. One of the center was actually Pune also. There was a meeting of the experts, we all sat together, and the only thing that we realized is, how will you identify non-severe TB? If you say lymph node TB as non-severe, we have this study on mediastinal lymph node TB which says most of the patients required an extended duration of treatment for almost 12 months. Why? Because these nodes were still caseous and necrotic even after 6 months when we did a HRCT. So to say that lymph node TB will be this, so how do you identify that non-severe TB? That's going to be a problem in this. So at the moment it's still not implemented into the program. Then we look at paradoxical reactions. So many of our patients will develop new lesions. Say you may get tuberculomas that are increasing in size, you may get lymph nodes that are coming up, a pleural effusion that is coming up on treatment. That doesn't mean the TB is worsening, it's just an immune reconstitution. So in those patients, the treatment duration is much longer. So again, how do you decide non-severe TB? So this is the reason why we still haven't implemented this 4-month regimen. Now TBM, there have been new guidelines which says that instead of 12 months therapy, as I told you in TBM we don't know the dose of rifampicin, how much to use. And I told you ethionomide has got excellent penetration into the CNS. This is based on South African data. So they use this regimen in South Africa. They use 6 months of HRZE and ethionomide. They don't use E, they use ethionomide. So they use 6 months of INH, rifampicin, pyrazinamide, ethionomide. And they found excellent results. Will 6 months be enough? Now that is a criteria. How do you decide end of therapy in CNS TB? We've had these patients where we've had tuberculomas. And in tuberculomas, you don't really know when do you stop. There have been some patients where we've given therapy for almost 4 years. There are some who go on for 2.5 years. So we look at radiological resolution. What is the radiological resolution? Either the granuloma disappears, the tuberculoma, or it gets calcified. So if you look at this, most of the patients would require treatment for much longer time. Much longer time, almost 2 years. So again, if we go to ethionomide-based regimen for 6 months, we need a biomarker which tells us, yes, TB is under cure and we can stop the therapy. It's not going to be that simple to implement that CNS regimen of 6 months. Now, if you come to drug-resistant TB, the grouping of the drugs keeps on changing as more data comes. Earlier, delaminate was in your group A and then it's now become group C. So now your regimen is all the drugs from group A if you can use. So you use a quinolone, bedaquiline, linezolid. Then group B, you need to have 5 drugs into your regimen. So group B, you can use cycloserine or clofazimine. So that makes your 5 drugs. So that's your regimen. If you cannot use group A, group B, all the drugs, then you come to group C. And your group C is ethambutol, delamanid, pyrazinamide, meropenem, amikacin, all these, PAS, ethionamide. So totally you need to make 5 drugs. And this is the regimen that the government is implementing. So you have shorter oral regimen, which in Mumbai we are just not able to put it into place because most of our patients are resistant to pyrazinamide, ethambutol and ethionamide. So we can't get this oral regimen shorter. So we actually go into the longer regimen. And longer regimen, we don't follow this, we go according to the DST pattern. Now in the TB program, initially the 2 new drugs that have come out are bedaquiline and delamanid. And both these drugs are not available for private practitioners. It's only through the designated DRTB centers that you get these drugs. Bedaquiline and delamanid are not recommended for children less than 5 years by the government, though the WHO has recommended it. The reason is we still don't have DCGI approval, so we are not able to use it. So we use these drugs on a compassionate ground in children less than 5 years. The problem is we don't know the ideal dose in less than 5 years. You need to take a hospital administration permission when we are using it in less than 5 years. You have to take the parents' consent. You have to take a DRTB committee consent if you are going to use it in less than 5 years. So a lot of restrictions in using it less than 5 years. It prevents misuse. The disadvantage is that the healthcare worker has to be committed to go through all this procedure. And the pulverization of the drug is another problem. So these were about the drugs and the regimens. I didn't go into the BPAL regimen at all because BPAL is a new, we have a new drug known as pretominib. And that has been approved now by the FDC. The thing is, here in India, it's still not approved for children. So I'm waiting for that approval from children, which will change the regimen completely of the way we manage DRTB. Latent TB, you have source case, you have exposure. These contacts will not get infection, no disease. The people who will not get infection will be around 70%. People who will get infected will be around 30%. Chances of developing TB is 5% in the first 2 years. Around 25% lifetime is what you will get. So latent TB pool is the most important thing if you really want to eliminate TB. Yeah. So how do we look at latent TB? This is a whole chart that the government has formed. I'm not going to go into this, but it tells you that once you prove latent TB on the basis of your IGRA, so less than 5 years you're going to treat, irrespective of what the TST or the IGRA is. More than 5 years, based on the IGRA, if it's positive, you will start the latent TB treatment, provided you rule out active TB. All HIV patients will go on IPT, that is your preventive therapy. Whenever you start ART, you're going to start them once you rule out active TB. So what is the preventive therapy? You give 6 months of daily isoniazid, or you give 3 months weekly of isoniazid and rifampicin. So rifampicin is still not available in the program. It will come soon. The other thing is, we till now did not have any prophylaxis for DRTB. So now if your source case has got DRTB with quinolone sensitive, you can give 6 months of levoflox. And if you have INH monoresistance contact, then you can give 4 months of daily rifampicin. It's not that easy. I'll just discuss this last case. We had a 3-year-old girl. She was asymptomatic. Mother had pulmonary TB. She was screened for latent TB. Her monitor was positive for Quantiferon TB Gold Plus. Now in these patients we are doing Gold Plus, and that was also positive. So we gave her prevention therapy with INH for 6 months. After 21 months, mother again got TB, and she had pulmonary TB again. The child was again re-evaluated for latent TB. Her Quantiferon TB Gold Plus was again positive. So should we give TPT again? If our audience is not hypoglycemic, they'll answer. We should. So we don't have guidelines, right? So we don't know what to do. So now the advantage of TB Gold Plus. TB Gold Plus gives you this thing. It consists of 4 tubes as compared to TB Gold. So you have a nil tube which looks at the background interferon response. Then you have the nitrogen tube which looks at the T cell response independent of the antigen. Then you have a TB1 antigen which looks for CD4 response. And you have a TB2 antigen which looks at CD4 and CD8 response. A difference of TB2 and TB1 of more than 0.6 tells you active infection. Now if you look back at our case, TB2 minus TB1 was not 0.6, it was 0.13. So it's not active infection. So we didn't actually start treatment for prophylaxis. We just asked them to come for a close follow-up. So I would like to conclude saying that there are a lot of recent advances in TB, however the gap still remains. And to close the gap, more emphasis should be to decrease the latent TB in the population. Thank you very much.